Helo everyone, croeso I ail sesiwn wythnos gwerthfawrogi iechyd y pnawn yma. Welcome to the second session of the Value in Health Week and thank you for joining us this afternoon. I'm Rob Palmer and I'm a healthcare scientist at CEDA, which is a health technology research centre based at Cardiff and Vale University Health Board, and I'm also part of the analytical team for the Value in Health programme in Wales. So in this hour-long session, we'll be discussing the visualisation of PROMs, or patient-reported outcome measures. So PROMs data are pretty hot at the moment, and their collection and uses are really growing around the world, including here in Wales. So this is because patient-reported outcomes are a major factor in achieving value-based healthcare because they help to quantify the value of care given to a patient. And I'm sure we'll be hearing a lot more about this throughout this Value in Health Week. So I'll very quickly give a reminder of what PROMs are. So they are patient questionnaires, and the questions are on asking the patients on their quality of life and their symptoms. And they're generally two different kinds. So there are generic PROMs, which ask questions about the patient's overall health in general, and they are not specific to a particular condition, so they can be less sensitive to change due to treatment. But because of this, they do allow us to compare PROMs responses of patients with different conditions, and so that in turn allows us to do some cost-effective analysis or cost-utility analysis with them. The other type of PROMs are condition-specific PROMs. So these are questions that are specific to the patient's condition. So for example, a PROM called an Oxford Hip Score asks patients questions specifically about their hip symptoms and the quality of life due to their hip. So this type of PROM might be suitable for patients undergoing hip surgery, for example, but unsuitable for patients with other conditions such as heart failure. So because of this, these types of PROMs are much more sensitive to change, and they're often preferred by clinicians for use in the clinic because they are more specific to the condition that the patient is being treated for. So both generic and condition-specific PROMs usually consist of multiple choice questions, and the answers to these multiple choice questions are usually ordered in severity. And you may also come across a visual analog scale, or a VAS, which is essentially a scale where the patient is asked to mark on the scale between 0 and 100, where they rank their health on that particular day. And 0 is usually the worst health imaginable, and 100 is usually the best health imaginable. So usually then, the answers to the multiple choice questions can be combined to provide an overall PROM score, or sometimes called a PROM scale. And this is basically a summary score, which can make it easier for us to analyse and visualise this data. So if you're interested in hearing more about PROMs data, PROM scoring, or the aggregated analysis of PROMs, there's a session tomorrow morning at 9 called An Introduction to PROMs Analysis, where myself and Amanda Willacott, one of the programme managers for the Welsh Value in Health Centre, will cover some of these things in more detail. But traditionally, PROMs were collected on much smaller scales, often in clinical trials and so on. But as we're now collected on much larger scales, maybe on a health board or national level, and we're also collected more routinely as part of the patient pathway, we need to find ways to easily and effectively visualise this PROMs data in different scenarios to support healthcare provision. So there are a few things to consider before producing the nice graphics. So first of all, we'd usually need to bring a bunch of data together from different locations or data sets so that we have all the info necessary to show what we want to show. And I think Sally will touch on this later on in the session. We'd also want to make sure that we're using the correct visualization for the type of data we are showing. So for example, overall PROM scores can be considered as continuous data, but most individual PROMs questions are ordinal data. So we'd want to make sure that the type of visualization we're using is allowed for ordinal data types. We may also want to show as much info as possible on the graphic without cluttering it up. So for example, we might plot a bar graph comparing the mean PROM scores of two different treatments, and one appears to be a lot higher than the other. And that might prompt us to think, well, like we need to do something here, like drop in one of those treatments. But actually, if we plotted more information such as error bars, standard deviations, confidence intervals, then there might be a big overlap between those two treatments, meaning there's not as much difference as we originally thought. So it's best to avoid showing data in a way that would nudge the reader to draw a particular conclusion without giving them the full story of what that data actually looks like. So it's about being transparent in terms of the data we're showing. And a really important thing to consider is, who are our visualizations aimed at? So visualizations for clinicians will probably be different to those aimed at patients, and they'll probably be different again to those aimed at program or project managers. So this could be because of different levels of data literacy or knowledge around the data, different contexts that the data will be looked at, the different uses of that data, or maybe even personal preference, such as types of graphs, and the different fonts and different colours and so on. So the Welsh Value and Health Centre is currently putting together a research group, and one of the first things they'll be looking at is how to aim particular PROMs visualisations at particular audiences. So we have quite a lot of PROMs data collected in Wales now, and we're getting to the time where we need to start using it through things like data visualisation. So this will be an important piece of work going forward. So as this is still a developing field, and we're still trying to work these things out, we have some presentations today with examples of what's currently being done, as well as what's worked well, what didn't work well, some lessons learned, and some pitfalls and risks in visualising this PROMs data. So first we have Russell White, who is an information analyst at Swansea Bay. And Russ will be giving us examples of a variety of visualisations used specifically within a health board environment. They'd include what is working and what didn't work so well, and he'll describe the learning journey to create visualisations that meet the needs of clinicians. Then we have a presentation from India Nicholas and Adam Watkins. India is a project support officer in psychological therapies at Swansea Bay, and Adam is an information analyst from Improvement Cymru, which is the improvement service for NHS Wales. They'll be sharing some of their work in mental health and showing us some examples of PROMs visualisations that are helping clinicians make sense of their data. And finally, we have a presentation from Sally Cox, who is the Principal Specialist of Information for the Value-Based Healthcare Data Team at Digital Health and Care Wales. And Sally will be showing examples from a national development perspective. These include cohort level stuff, such as data dashboards, as well as patient level stuff, in particular tools for the Welsh Clinical Portal. So once we've heard from our speakers, I have a question for the panel, and we follow that with questions from the audience. I believe the recordings of all the sessions in this Value and Health Week, including this one, will be available towards the end of November on the Value and Health website. So please post any of your questions in the Q&A tab, and hopefully we'll have time to get through some of them. If you have a question about a particular presentation or for a particular speaker, then please let us know in the question text so I know who to put it to. So I'll pass you over to Russ now, who'll be sharing some slides with you.
Thanks, Rob. Prananda, hi, I'm Russ. I'm the information analyst in the value-based healthcare team here at Swansea Bay. Let's crack on with the slide, shall we? So I've been working here at Swansea Bay since August last year. This is my first job working in value-based healthcare. Before this, I worked in various NHS roles, always as an information analyst. So I've got far too much experience in SQL and report writing, but I have never tackled PROMs before. So I had a lot to learn when I first started. So I'm going to talk you through the journey that I've been on to try and make the PROM visualizations work for the clinicians that I work with. Next slide, please. When I got to Swansea Bay, there were already several PROM projects in place, each with their own piece of data and analysis. You can see that on the left of the slide here. Each project was kind of its own silo. It's completely isolated from all the other projects. The data was available from whatever the various different data sources, including the national platform, PKB and Doctor, which are two of our independent PROM platforms. But all the analysis and reporting was always done in Excel. Since I started, I've slowly moved each project away from the silo model. The data sources still exist, but now the first thing I do is take the data and transfer it into our local data warehouse. You can see this on the right hand side of the screen there. For each project, I've also then implemented SQL to do the analysis and Power BI for the visualizations and the reports that sit on top. I've also taken the opportunity to build a new central analysis report, which combines all the different projects together into one highlight report, which we use internally within the team to monitor the progress across our different projects all at the same time. Next slide, please. So in my first 2 weeks of the job last year, I was asked at short notice to provide a report on EQ5D data for the heart failure project. Now, these are two images from that first FATED report. I used a simple line graph for the profile scores for the EQ5D, that's on the left. I did manage to come up with a longitudinal concept. I don't know if you can quite see it there, but it goes baseline Form 2, Form 3, and Form 4. These are rankings from the date completed for that each patient has filled in their forms. I then had to also put some actual writing underneath it to say downwards trend equals improvements and upward trends equals worsening, to try and explain what the lines meant. And I came up with some a mix of interesting colors to use for some bar charts on the right hand side there, just to show numbers of forms involved. Now, I sent this out and I did get some interesting feedback from the staff involved. Everybody liked the baseline Form 2, Form 3 concept to show the longitudinal analysis. But most people said that the line graph was too simplistic and the colors on the bar charts were just confusing. Next slide, please. So I took a big step back and came up with a plan to improve these visualizations. I first went away and spent a long time talking with the clinicians and the managers involved in each project to understand what was important to them and what they would like to see in their reports. These images here are from the first report that I created, the TAVI project. This is the first implementation of the value-based healthcare branding that we've introduced within our team, which is now consistent across all our reports. It's got the blue lines at the top and the bottom. I've also moved the visualizations away from Excel and into Power BI, but the data is still kept in the original data source files at this stage anyway. In this report here, I've tested out some simple pie charts for the patient populations. These were quite liked, but they weren't hugely useful for the clinicians. And I've started to build a common element across all the reports at the top of the project, which, as you can see, is the forms received and the patients who completed them. And that works towards a completion rate, which we start calculating for all of our reports now. And then on the right-hand side, you can see that I've started to introduce a score chart that shows RAG rating to show the performance. That's red, amber, green. The more green you see in the visualization, the better the performance. And this concept is very basic, but it went down an absolute storm with the clinicians. They absolutely love seeing the green on their paper, just so that they've done well. Next slide, please. Then I moved on to quite a major project, which is urogynecology. Now, the clinicians in this were more interested in seeing the PROM responses at an individual patient level rather than averages across the whole data set. They use these individual responses as part of direct patient care. So they needed a Power BI app or report that is completely tailored to their service. The image on the left shows that I've taken the usual longitudinal concept of baseline Form 2 one step further and measured the period in time between the forms being completed. So this patient here has two forms. The first one is still baseline, but the second one was completed 2 months after that baseline. So you could have month 2, month 3, month 7, perhaps, if the fourth one was a few months after that. The image on the right is from what's called the voiding chart PROM, which is essentially a bladder diary that a patient completes over 48 hours. You learn a lot about this sort of stuff when you're doing value-based healthcare. The patient has to fill in a log of everything they drink over this 48-hour period, and then log every time they go to the loo for a wee as well. And the clinicians like to see the statistics, which is in the middle of the page there, for each of these bladder diaries that the patient has done. And they also want to have a rough idea of what the fluid in and fluid out was. And that's on the left-hand side of the chart you can see there. Next slide, please. This is from the same project, the urogynecology as well. This is a PROM called the Queensland Pelvic Floor Questionnaire. Now, the PROM consists of 4 domains, and within each domain, there's a number of questions. Each domain is scored, and the clinicians use a form of shorthand to analyze the responses to the questions within that domain. And I've tried to automate this as much as possible for them. So you can see here that on the left-hand side, this patient has given us 2 responses. And on the first one, for their bladder function, they've scored a total of 58. And then there's all sorts of bothersome frequency, and that's all the shorthand that the clinicians used to write out manually, and we've automated that for them. So you can see that the bothersome score was 3. The urgency has got 2 plus next to it, which is the clinician's shorthand for very urgent, very severe. This allows them to see really quickly an overall patient change from one form to another. And if they then want to drill down into it, they can, and that's the image on the right, where they just click on the bladder function and it expands, and you can see the actual questions that the patient filled in underneath that with the individual scores and the responses. And I've kept the color coding for the scores, so the red ones jump out straight away, and they can see that this is where the patient is having the most problems. This is actually working quite well, this particular chart. Visualization, I should say. Next slide, please, Gareth. So this is an example of a more advanced longitudinal analysis, and this is going back to where I started, the heart failure redesign project again. By now, what I've done here is I've moved to a box and whisker chart analysis, which shows the mean score with the blue dots and maximum and minimum, which are the whiskers that go above it, and the grey bars are the upper and lower quartiles of the, to give you a range of the responses we have. What I've also managed to do here is I've kept the baseline form 2, form 3 concept, but in brackets after each of those, I've included the number of forms involved in this particular cohort. So you can see that we had 451 baseline forms, 171 form 2s, and then only 2 patients who've given us 9 forms. I've also color coded the 5 strips that you can see. One for this is the EQ5D, so the lowest, the best score you can have is a 11111. I think I gave it too many ones here, and the worst is a 55555. So I've put some RAG rating behind it, and this is done in Power BI, and this is actually 2 charts on top of each other. The box and whiskers chart has a transparent background on it, and then behind it is just 5 color bars just sitting behind there. That was the only way I could get that to work. But the good thing with Power BI is that you can stack the visualizations on top of each other, and the user doesn't know when they look at it. Next slide, please. So the reporting model that I've developed by now, this is coming up to modern recent examples. This now is consistent across all the reports that we have, with the blue line at the top and everything. This is from the IBS project that I'm working on, and there is a clear distinction in the cohort here between pre and post patients for the IBS service. It's a really simple page, and it's showing the difference in outcomes between these 2 pre and post cohorts. The increase in green in the post cohort represents the positive impact that the service has had. If you want to know more about the IBS project, I think my colleague Sinead, who works on the IBS team, is discussing this more in her presentation on Thursday. Next slide, please. Okay, so this is the headline summary page for the exercise lifestyle program. And this is a really busy page, but it's designed to be busy and to show all the key indicators from the project in one go on one page. The ELP project, it has clinical assessments, so PROMs, as well as the patient reported outcomes of PROMs. And there are 2 distinct sets of patients here. There's the MCAS, which are in the blue section at the top of the page, and TNO patients who are in the orange section at the bottom of the page. Both sections do exactly the same sets of questionnaires, and so they have exactly the same indicators. And in the middle of both the orange and the blue section, hopefully you can see that we've got baseline average value. So that's the average that was taken when the patients first started. So for instance, with the MCAS patients, you could see that their weight was 97 kilograms on average when they first started. And then the line underneath that is once the patient's done a follow-up, we've tracked the average change from their baseline to their follow-up. So you can see that again for MCAS patients, on average, patients have lost more than 2 kilograms as a result of working with the ELP program. Next slide, please. So as I mentioned before, storing all the PROM data in the local data warehouse has also allowed me to produce a central report, which we use internally to highlight key elements of each project that we work on. The bottom left, that small little chart down there, that's the average completion rate that we have for all of our PROMs, combined across all the providers and all the projects. And then I've also managed to in tabular format produce a table, one table for each of our projects. So that's the IBS and the lymphedema, and you can see each indicator going on. So our report runs through a few pages, maybe 6 or 7 pages, and it looks mainly like that, with the key highlights from all of our projects together in one place. Next slide, please. So coming back to this slide that we were at to begin with, I just want to show that we do have plans for the future as well. We're currently working on the data flows that are used for each PROMs platform provider, so the PKB and doctors of the world. We're trying to automate them as much as possible using Fire API to get the data automatically into the local data warehouse, as instead of, at the moment, I have to manually download the data from their web facing interfaces, and this will automate that. That will then allow me to streamline what we have in the data warehouse much more in line with the new DSCNs that are being produced by the National PROMs Data Flow Development Group. And then once that's done, we can start submitting these more regularly to DHCW and hopefully in the long term to NDR. So there's a lot more developments coming in the near future for me as well. I think next year will be equally as busy for me. I think next slide is just me saying diolch yn fawr. Thank you very much.
Thanks, Russ. Thanks, Russ. Yeah, some really good examples there and a real wide variety as well, which is good to see. I also like that we know that clinicians like green, so that's a really top tip, which I like, so thank you. I'll pass over now to India and Adam, who'll be talking about PROMs in mental health.
Hi, my name's India and I work in Swansea Bay University Health Board.
Hi, and I'm Adam Watkins. As the slide says, I'm an information analyst in Improvement Cymru. I'll talk a bit more about myself and my work later on.
So I'll start you off. If you wouldn't mind going to the next slide, please. So today we will cover the COM, implementing collection, and Adam will run through the analysis and the visualization. Next slide, please. So from the national outcome document, as a service, we decided to use the COM, also known as the Core 34 and the Core 10, to monitor change in patient outcomes. As a service, we also decided that we would use these forms pre, mid and post therapy. Core 34 has 6 related risk questions and Core 10 only has 1. Next slide, please. So these were something that I had to consider whilst before implementing the collection of the outcomes. Availability of systems to collect data from service users, licensing and information governance. The combination of Microsoft Forms and the core resolves this. The Core Systems Trust actually made a template form available for Microsoft Forms where we could use Core then to use for service users. We were able to use this without having a Core license, but we had to have a Microsoft Forms license. So next slide, please. Our process of collection includes the therapist emailing service users ahead of appointment with instructions and a web link. The service user then opens the assessment in a web browser and completes it, identifying themselves by entering their email address. Myself and individual therapists can view the completed assessments in Microsoft Forms. Although we identify the service users by their email address, this is working well at the moment, but we know that we could improve this. And next slide, please. But what Microsoft Forms doesn't do is it doesn't collect COM scores. It doesn't link assessments over time for an individual service user, and it doesn't flag assessments with risk-linked answers. Also, it doesn't provide any visualization or other analysis. And I'm going to hand you over to Adam. Thank you.
Hi, so as I said, my name's Adam Watkins and I work for Improvement Cymru. Improvement Cymru has quite a wide range of programmes and providing bespoke support to health boards, and one of those is the rollout of the mental health outcome measures programme, which at the moment has mostly been focused on the readiness of teams from a sort of staffing and culture point of view. We don't at the moment have a huge amount of sort of informatics support, which means that often teams are having to sort of work out how to collect and analyze PROMs themselves, which at the moment is often bits of paper and Excel workbooks, so I'm completely honest. And we were really excited to hear from India in Swansea Bay about how they've sort of solved some of these things by using Microsoft Forms. But then it also became quite clear that there was some sort of opportunity for synergy here, because then we could work with India to find some way of actually making use of that data in a more powerful way to analyze it. Next slide, please. So the way we went about trying to provide a way for India and the therapists in Swansea Bay Psychology to analyze the data that they're collecting core OM was to build an app in a web framework called rShiny. So this is sitting on a Public Health Wales web server. Any data that you upload into it doesn't get stored with Public Health Wales. It's not something that we can look at. It sits in the memory of the server while you're using it. This is something that we've cleared in information governance, but it allows us to provide a tool that people in health boards can then use to upload data that they've been getting from Microsoft Forms. Next slide, please. The process for actually getting data into the Explorer is unfortunately still quite convoluted at this point. So you've got to go to Microsoft Forms, as India says, she and the therapist can do that and see the assessments, but then you've got to save as and download a copy of that data in Excel and upload it into the web browser. None of this is ideal, and I think we need to look at ways that we might be able to tackle it either in the short term using like the Microsoft Power Platform, or thinking about the things that we talked about in the last presentation by Russell. Can we get some of this information actually flowing from Microsoft Forms into proper data warehouses and ultimately the NDR and things like that? Next slide, please. One of the other sort of technical issues that we had to overcome before we could even get to visualization was the fact that the assessments data doesn't tell you, like, is this a pre, post or mid one? So what it actually has to do is try and link the assessments up over time. And you can fiddle about with some of the assumptions there if you've got really sort of high rates of re-referral or you're delivering really long assessments, but the defaults tend to be pretty sensible, although India and I have learnt over the weeks that maybe we needed to nudge them up a bit, because when people are actually doing the forms, which are sometimes before their first session and after their last session of therapy. But the point is that the Core OM Explorer sort of handles all this aspect for you, starting from the raw data of individual assessments. Next slide, please. Okay, so we finally get to data visualization at this point. So once you've done that, once you've uploaded your assessments, once you've linked them back into episodes of care, then it can start pulling out information like the first score for all the people that have entered your psychological therapy service. And I suppose there's a few things which I can try and emphasize, even just looking at this slide. So this is like a slide showing distribution of individual scores. So already quite a strong emphasis on the idea of showing individual scores and their distribution rather than trying to reduce it to summary statistics, which I think can often be quite confusing unless you're really clear on the nature of the distribution of the underlying data. Secondly, that we try to be really careful with the use of colour and colour choices here, so bearing in mind like colour blindness, and also thinking about accessibility. The whole of the Core OM Explorer tries to show stuff both in terms of having a chart on the left-hand side, but then also trying to set it out in text on the right-hand side. And I'm not sure that this is completely successful at this point, but we have had feedback for different bits of it that people wanted the information presented in multiple different ways, and that's, I guess, drawing on like differentiation as a thing in like teaching theory and that sort of thing. I know if you hover over things like healthy or severe, those words in scare quotes in the text, then it gives you the definition in your web browser as well. Next slide, please. The next thing that it can show then is change between the earliest and the latest score for all the service users that you've uploaded, and it's being able to link together episodes of care with multiple assessments for. And again, a really strong emphasis on trying to show individual patients and the distribution of change and their scores, rather than trying to reduce this to summary scores or other kinds of like statistics that you might produce on this. So what you've got on the left-hand side is a scatter plot. Each dot is a patient, or I guess specifically an episode of care. On the bottom, you've got the score that they came in with, and along the side, you've got the score that they left with. So in the top left-hand quadrant, you've sort of got people who got worse, that they came in with a low score and left with a high score, indicating a higher level of distress. And in the bottom right-hand corner, the opposite. People came in with a high score and left with a low score. And it tries to guide the user in terms of actually making sense of whether or not change is reliable or not. So You need a reduction in score of 5 or more to count as reliable improvement. Moving to recovery means going below that sort of population cutoff, having also shown reliable improvement. And again, it's trying to show stuff using careful choice of colours. As I said, I appreciate several times, like an emphasis on like showing individual service users and also presenting information both graphically and in text at the same time. Next slide, please. This is just showing some actual data very briefly to give you some other ideas of actually what the distribution looks like. I know you can also see a couple of things here which I've not shown. So it does show box plots alongside stuff like the scatter plots. I'll talk really briefly about the drop downs at the top in a moment and how those relate to being able to compare different groups of service users. And on the right here, you can see something which I'll show you a bit more detail on the next slide, individual service users charts over time. So next slide, please. So if you click on one of those dots in the change view, for example, then it takes you directly to a service user's record, and you can see how, for example, this person had relatively high scores for the first 3 sessions, dropped, and then continued to have low scores for the last 3 sessions. I know this is actually a perfect example of like how we've responded to a request for greater differentiation. This view now shows a table of the scores alongside, but you can also hover over the points and it shows you like the scores and things like that. Next slide, please. So I would note there are lots of outstanding issues, I think, that India and I are continuing to discuss and how to discussing how to fix them as well. So it's clear that some of the processes for collecting and using this data is quite unwieldy. India and I have basically had to build things at different points in the process to try and work around the lack of proper systems. We've generally tried to stay away from showing subscales in the core OM stuff because we don't think that information is that useful, but there is something about making sure that the information from the risk questions is highlighted in a way that is safe and supports therapists identifying people who are answering those questions in a way which indicates higher risk. There's a big thing here about wanting to be able to link episodes with more context that we want to be able to see, like, is there a difference in terms of who is responding to different interventions, for example? And one of the big challenges there is to do with data flows and being able to link episodes of care with the deprivation of the service user or their gender or their age and things like that. And harking back to something that Robert said earlier, therapists and counsellors actually quite often prefer PROMs that are much more condition or intervention specific than the core OM. So we've actually had quite a lot of requests to try and build the tool out for other PROMs that might engage therapists a bit more. Thank you very much.
Thank you, India, and thank you, Adam, for that presentation. Really interesting to see your work. And I found it interesting that you were deliberately avoiding to do some summary statistics on some of the more dashboard-like visualizations, which is probably a good point that this maybe the more dashboard-like visualization should be treated differently to bespoke analysis. I think that was an interesting point that you raised. Pass over now to Sally, who will talk about PROMs visualizations from a national perspective.
Thanks, Rob. Right. Okay, so I'm Sally Cox. I lead the Value in Health data analysis team within DHCW. We currently support, we're supporting the Value in Health programme with data analysis from the National Data Warehouse, and we're currently creating condition-specific data dashboards for the service on a population basis and patient-level visualisations embedded within the Welsh Clinical Portal. Today, I will take you through a bit of background of the national PROMs data in Wales, the electronic PROMs platform, some challenges, enrichment to the data set that data linkage brings, followed by some patient level and cohort level visualizations that we have done to date. So we're quite early on in our PROMs journey in Wales, and there are lots of things happening through the Value in Health programme and wider that will enable us to create meaningful, comparable analysis and visualizations. Next slide, please. So in NHS Wales, PROMs have been collected for a number of years, but primarily by local initiatives. And so this has created a limited and coordinated collection, which has reduced opportunities for shared learning. So the PROMs and PREMs and Effectiveness Programme was established in 2016 to standardise collection across Wales and to develop and roll out an electronic platform for PROMs and PREMs for secondary care patients. The technical development of this platform, including the rollout and the support, was managed by the NHS Wales Informatics Service, which is now Digital Health and Care Wales. So this is the national organisation that's building and designing digital services for health and care in Wales, and that's where the national data sets are held. So the national platform was born to unify this collection into a central repository, which could then be linked back to clinical and administrative data held within the national data repository within DHCW, making it available back to health boards and to support the VBHC agenda. So, however, in addition to this national platform, there's many other commercially available PROMs systems. So some of them have already been spoken about by Russell with Doctor and Patient Knows Best. And health boards are free to choose whichever supplier of PROMs that they wish, and they may even choose different suppliers across different and sometimes the same specialties. So in addition, there could be collections on paper forms, which may or may not be later inputted into the local system. And then, as India and Adam were talking about, some teams have also started creating their own collections using Microsoft Forms. Next slide, please. So what can we do? So these multiple collections are on multiple disparate systems, and this creates huge complexities when trying to collect data into a single national resource. Furthermore, to enable meaningful, consistent analysis at both an individual and a population level, we need to be using standardised data. So we need to make sure that we're collecting the same data in the same way nationally, irrespective of the system used, and that everyone use pre-agreed national standards so that there's no requirement to map local values to national codes when it comes in centrally. So to embed these standards, the National Data Standards team, led by Gareth Griffiths, the Value in Health team and representatives in the health boards have been working together for quite some time now to create a set of data set change notices, or DSCNs as we call them, which provide the standard coding structure and process for central submission, storage and communication of PROMs data. And these are independent of the platform or source application that's used to capture those PROMs. So the first 6 DSCNs were approved by the Welsh Information Standards Board on the 23rd of September, and we're hoping that the remaining 30 pathways will be presented for approval by the end of this year. So the DSCN data standard defines the information specification and serves as a basis for the development of technical and interoperability standards necessary to unlock data from PROMs applications for both national and local purposes. And you can hear more about how the Value in Health team are supporting this process in the interoperability session on Thursday at 2 with Saeed Shadi, Stephen Frith and Angela Parrott. Next slide, please. Value in Health aim to create a data-driven system where information collected is used more efficiently and therefore more effectively. And this slide shows how patient-level PROMs visualizations have been used within direct care to enhance communication between patients and the healthcare professional. The PROMs data from the national platform has been used here to create patient-level visualizations of PROM responses over time. And this slide shows screenshots of the lung cancer patient PROM visualizations that have been developed for daily clinical use in the management of lung cancer. And this is available within the patient electronic record in the Welsh Clinical Portal. So the motivation for this development came from clinicians within Hywel Dda Health Board to start collecting PROMs in their lung cancer clinics. The data view was conceptualised and defined in collaboration with the Health Board and tested and approved by the clinical team collecting the data. The team at DHCW created and operationalised the tool to allow clinicians to view patient PROMs as data visualisations. The model that was developed for these lung cancer visualisations is now being used as the basis of development for heart failure and hip and knee PROMs, with more planned for the future. This tool was developed within Logi Analytics, which was then embedded within the Welsh Clinical Portal, and the data here is refreshed daily. Next slide, please. So now from patient level visualizations to cohort or population level visualizations using aggregated PROMs. So what questions are we trying to answer from these PROMs? So from engagement with stakeholders, we have found that questions are often around collection, maturity of PROMs programs across NHS Wales, who's collecting, what are they collecting, or completion rates, response rates of PROMs from patients invited to complete. Then we have questions around symptom burden of patients at various time points, but mainly comparison of outcomes by treatment, interventions, demographics or costs. Next slide, please. This slide shows some visualizations created in Power BI. The visual on the left illustrates PROM data collected on the national platform and shows the uneven implementation across the health boards, with some collecting across all conditions and some only in specific specialties. The generic PROM dominates, as you can see, within each health board. Orthopedic PROMs are the next common, with hips and knees featuring heavily. Visual on the right is an example of a simple visualization from the lymphedema dashboard. It shows the percentage of PROMs that were fully completed of those that were submitted online. It includes patients who did not complete a PROM due to undergoing intensive treatment, or those that had recently submitted a PROM prior to being invited. However, it does not represent the overall response rates for lymphedema PROMs. Next slide, please. So one of the first issues the team faced when we began to look at PROMs data was that patients can have multiple PROMs for a specific time point. This can occur on occasions when a patient does not complete a PROM in one sitting, and also because the system allows for ad hoc submission of PROMs, with the invite to complete the PROMs remaining open. When faced with these multiple PROMs for patients at the same time point, which do you use? We have found that this depends on the situation. The screenshot above shows some visualizations of heart failure PROMs on the left and lung cancer PROMs on the right. Here we've simply used the first PROM in the dataset for each patient to represent a baseline measure of symptom burden and patients attending clinic. Patients may be at different stages of disease when they first attend, but this also gives the clinician an indication of the main symptoms being reported by their patients. So in contrast, when working with PROMs with overall scores like the Oxford Knee score, the important factor here is that the patient answered enough of the PROM to generate a score. So in the case of multiple PROMs for Oxford Knee PROMs, we would take the PROM with a score, and if there's still multiple PROMs with scores, we would have to apply additional rules, such as choosing the PROM closest to the procedure, for example. Next slide, please. There is a choice when analysing PROMs data as to whether to examine all PROM records, as has been shown in the past two slides, or just those that have linked to additional data sets. So to answer more complex questions like those that involve comparison of outcomes data, this usually requires the data to be linked. Due to the voluntary nature of PROMs, it is unlikely that linking to clinical data will match all records. The advantage of examining only these records that link is that the linked dataset offers a richer set of information, analysis by ethnicity, detailed procedure and diagnosis, or other outcome data. However, you must expect a loss in numbers on linkage due to data quality and completeness issues on both datasets. So the Venn diagram above shows what happened when we first linked 5 years worth of knee replacement procedure data in Wales with the Oxford Knee score dataset from the National PROMs platform. So out of 18,750 knee replacement procedures that took place in Wales over the last 5 years, 859 had either a pre-op or a post-op PROM. That was from a data set of 1,600 Oxford Knee PROMs pathways. Further, only 41 of the linked procedures had both a pre and a post-op PROM. Next slide, please. This is a visual from phase 2 of the National Knee Arthroplasty Dashboard, which is due for release later this year. It shows PROMs completed for knee replacement patients around the procedure date, which is shown on the chart by the yellow line. The blue dotted lines represent 6 months, 1 year and 3 years post-procedure. The x-axis represents days plus or minus the procedure date, with the procedure date being day 0. For this analysis, only patients that linked to the National Secondary Care dataset with a knee replacement procedure code were used. We then used this visual with clinicians to determine the time boundaries required to represent pre-op, 6-month, 1 year and 3 year PROMs. And these were defined as a pre-op was anything before the op day, 6 months was defined as a PROM submitted between 5.5 to 9 months post-op, 12 months, PROM submitted between 9 and 15 months, and so on. Next slide, please. So in summary, these are the challenges and lessons learned in our PROMs analysis journey so far. PROMs data in NHS Wales is scattered on multiple systems, being local, commercial and national, and getting this data to flow into one single national repository in a standardised format is complex. However, this work has begun on creating both data and technical standards. Linking data can enrich your data set, but you must expect loss of numbers due to incomplete or uncoded data. We recognise that data linkage and comparative analysis requires a much larger data set than we currently have. And to address issues such as confounders, missing data and bias, such as that posed by the digital divide, as we're collecting data on an electronic platform. Analysis of PROMs that does not require linkage, such as collection rates or symptom burden, should use all PROMs records available. We have followed this convention within the dashboards and used both linked and unlinked PROMs data. Due to the complexity of the data, we have to apply rules and logic, and this may be case specific. For this reason, we recognise that it's important that methods are transparent and consistent to prevent discrepancies between organisations, as the national data is available to a number of end users. To support this, a data dictionary will be developed as part of the PROM standardisation work, and a data products subgroup has been set up as part of the Value in Health data work stream. So this is an analyst group which meets monthly and has representation from health boards and other NHS Wales organisations, and aims to become a centre of excellence, developing, documenting and sharing methodologies to facilitate meaningful analysis and reproducible reporting across NHS Wales. So finally, we've learned to align PROM data to events and time periods to enable comparison. For example, when determining what is a pre-op PROM and what's a post-op PROM. These are they are defined pre and post PROM tools available for most pathways, but what we found is that pre-op PROMs are sometimes completed by the patient post-operatively and vice versa. So data linkage to align the PROM with the procedure date and the pre-post-op analysis is the more robust way to analyse, as the pre-op form filled in post-operatively can still contain useful data and therefore does not need to be discarded. So overall, nationally, PROMs data in Wales is still in its infancy and will take time to develop. However, as it matures, the availability of a national data set has the potential to support quality improvement work and comparative analysis and even cost-effective analysis. So we will continue to work with clinical and analytic teams across Wales to ensure that we produce meaningful outputs. Next slide, please, and thank you.
Thanks, Sally. Yeah, interesting presentation. It's good to have a reminder about the mountain of work we needed to for data standardization and data linkage before we could do the visualizations. It's a good reminder. I'll just point out that some of the challenges that Sally mentioned there towards the end of the slides are going to be discussed more in tomorrow's session at 9 o'clock as well, if you're interested to hear more. I've got a question now for the panel. I'm hoping to come to all of you for comment, so maybe I'll come to Russ first, if that's okay. So the question is, PROMs data visualization can be used both at patient level to monitor conditions and at aggregated level, either as a needs assessment tool for service planning or for benchmarking to drive quality. So the appetite for benchmarking and evaluating services by comparing to a standard based on PROMs is growing, but some say there are many risks associated with this. Can you comment on the main benefits and risks of benchmarking based on patient outcomes? We can do Russ first, please.
It's a good question. I think the benchmarking is a good concept and very difficult to achieve correctly. I think that one of the key things in the question there was about an agreed standard. It's very hard to make sure that the standards that you agree to benchmark yourself against is the same across the entirety of NHS Wales. I mean, in Swansea Bay, we have one service that is probably, every service we have is replicated across every health board, and how that is implemented is unique to that health board for whatever variety of reasons. And so whatever standard you benchmark against, each health board has to know about and sign up to and agree to, and that probably limits what you can actually benchmark successfully against each other. One clinician will do something in one way, and another clinician will do the exact same procedure in another way, and that will give you a different outcome. And so I think there's a danger in automatically looking at a benchmarking analysis that's done nationally or comparatively and saying the one with the worst outcome is performing worse. That isn't necessarily the takeaway message. What I would want to see is a more nuanced understanding of what that benchmarking actually gives you, and a better understanding. I would look at that and go, why is that outcome different, and then go back to that health board or that particular specialty and want to drill more into it before I then said you're doing worse than the others.
Thanks, Russ. Adam, your comment?
I think Russell's point that actually like the immediate reaction always has to be to try to understand more about what's actually going on with the services and the people engaged with them has to be like the starting point for if it's going to do any good. I guess thinking specifically about mental health services, I think there are probably two things to bear in mind. Firstly, that you need to take complex causal routes to distress, mental illness, and then back towards well-being seriously. That there are usually many other factors why people present to mental health services that aren't in the control of those mental health services, and that actually a lot of variation between different parts of Wales will be down to those factors. And it's then tempting to fall into sort of this pit of risk adjustment where you try and take all the things that are actually interesting and relevant as to why some people are getting better and some people aren't, and hide those away before anyone's prepared to talk about the data. When in fact maybe what that points to is the other way around, is actually we should be looking at within services, can we identify who we aren't helping, and then ask that question about like who are they, why do they have different reactions to our interventions than some other people. And I suppose the second thing is that we have to hold on to actually what are our values and who deserves care. We have now seen over half a century of reducing the proportion of health services and health resources and mental health services which are directed at people who are seriously unwell, on the basis that it is more efficient and more effective to treat people earlier. So you have this very well-meaning ideological commitment to prevention, admittedly in the context of factors outside of health not really being taken seriously. So again, you've got those things of trying to focus on stuff in the health service when in fact it's so much outside of the health service that you need to look at in order to make sense of how people are responding to those services. With the upshot is that after half a century, we still have people who are seriously unwell, and we aren't necessarily giving them the resources they deserve. And so you get this vicious circularity of showing that some services are performing badly, effectively, and then trying to remove more and more resources from them, making it harder and harder for them to actually perform well. While at the same time, we have a really heavy focus on like being able to give people heavily manualized CBT as early as possible, which is only of limited value if you're being evicted, for example, which is going to be an experience that more and more people are going to be having over the coming months after the last 2 or 3 years. So I think it's those two things to bear in mind, that actually taking seriously why you see those variation in outcomes, and then also bearing in mind that even people that we find it difficult to treat effectively now still deserve the help of the health service.
Thanks, Adam. India, can I come to you, comment on?
I think we must ensure that processes are in place to encourage change and recovery for our patients. PROMs would help us understand this. Based on patient PROMs, we may use resources more effectively, focusing on gaps which would allow service development and strategy to support patients in the most effective way. The risk is that we only develop services based on existing patients and not the wider population need.
Thanks, India. Sally, do you have anything to add? Or?
Yeah, I mean, I have concerns about consistency of the data, the standardising or the non-standard of the standardising of the data, as Russ said, and as I mentioned as well earlier in my talk, we need a much larger data set than we currently have to be able to do anything, any sort of, even start thinking about things like case mix adjustment and benchmarking. So yeah, I mean, for now, yeah, no.
Thank you. We've had some questions in while you were giving your presentation, so I'll go through a couple of those. The first one goes for Russ. The question is, are the Power BI PROMs visualizations used by Swansea real-time updates or refresh at specific time intervals? And are there patient-centric visualizations accessed via the electronic patient record?
They are currently refreshed at specific time intervals. I have to download the data myself from the various different providers once a month. But we are working towards making them more real time. I don't think they'll ever be 100% real time though. The nature of PROMs is that, you know, a patient tends to fill them in at home in the evening, and then that data will get collected somewhere centrally in some provider, and then that has to be processed by that provider, and then it takes some time at least for it to feed through to us. So the quickest I could see it happening would be within a day or two after the patient has completed. I don't think we're ever going to get to 3 seconds after the patient's completed. It will turn up in the database and in the reports. In terms of the patient, it being in the electronic patient record, the national platform, Sally's probably a better place to answer this than me, I'd say, but the national platform, because it's national and that's where the our WPAS data comes from, yes, that does feed back in. I don't know if patients can see it themselves. I'm not sure about that one, but I know that clinicians can see that straight away. But anything that comes from any of the other providers, doctor or PKB or ProMap, is always going to have a lag and does not end up in the electronic patient record yet. But that would be the very long-term goal, I would say.
Thanks, Russ. I think we might have time for another question. There's one here which I think is appropriate for Sally, but maybe some of the others can comment so just let me know if you can comment on it. So the question is, when our patients go to other health boards for treatment, are we able to identify these PROMs to consider the outcomes for our patients? For example, if a patient from Powys was referred to Cardiff for secondary care, can we identify those patients to see their outcomes?
We would be able to nationally, yeah. It depends on what views of the data you have back at the health board. I mean, it is possible. We can find out where the patient is treated and where the patient is resident. So yeah, we can, but it depends. Like I say, it depends on the views that have been provided back to the health board. Perhaps we can talk about that. They contact me. Perhaps we can talk that through.
Thanks, Sally. So I think we've got a couple of questions as well for India and Adam's presentation. So the first one, I think, is for India, maybe. How did you overcome the IG issues of patient identifiable data?
So after speaking with the information governance team in Swansea Bay, they confirmed that Microsoft Forms is now the default platform that we will use and is safe for us to use as well. Because that's one thing I did stress about, that, we were collecting patient information, and, would Microsoft Forms be safe? But they ensured us that it was appropriate for what we wanted.
Thanks, India.
Thank you.
So another question that's come in, we might have a couple of minutes, is do you use a consistent set of visualization objects, for example, box whispers, histogram or spider charts for every PROM tool, or do you tailor the type of objects used for each PROM tool the user needs? So I come to Adam first on that one, please.
So in the context of the outcome measures program, we have produced, I'm afraid, sorry for people, this will give kittens, an Excel workbook so that people can put their own data in and they can use that for different tools. And previously, I've tended to try and stick to actually the same scatter plot thing, because it emphasizes, like, here are individual scores, you can see the range of the scores, you can use color to highlight whether or not change has been reliable or not, and it does let you have a comparable, a way that lets you look across PROMs in a similar fashion by focusing, I guess, on like the idea of reliable change and on the idea of there being a sort of very rough population cutoff. So you can have the same questions of how many people showed reliable improvement on this PROM, how many people showed reliable improvement back to the level of distress or well-being or what have you in the general population. So I think if you can ask similar questions of PROMs, it makes sense to try and visualize those things that answer those questions in similar ways. Yeah, so I think a lot of the time it makes sense if you're looking at multiple PROMs to try and show them in ways that support meaningful comparison.
Thanks. Russ, you've got time for a very quick comment?
I quite like what Adam was saying about the scattergram. I haven't used that yet because the answer to the question is it's different for us for every single project that we work with. We have to work with clinicians first and understand what they need. I've only actually got one project where it's specifically individual data that they want down to individual patients. That's where I can see what Adam's doing becoming really useful for what I've got. Everything else is aggregated, and there does tend to be some consistency across that where, yeah, I would use box and whiskers and some spider charts and things to show, but still there's no guarantee that I'd use anything. It's more a case of I fire a whole bunch of different visualizations at the clinician and say, which one of these do you think you like, and explain them through them and say, well, you know, which ones they come back to say, yeah, I want that one.
Thanks, Russ. So I think we've come to the end of the session. We ran out of time, so I'd like to thank Russ, India, Adam and Sally for sharing their work with us today and some of the visualization examples and for answering your questions. I think the recording will be available towards the end of the month. So I hope it was useful and thank you. Goodbye.